Good afternoon. My name is Barbara Koenig. I'm from the Institute for Health and Aging in the School of Nursing at UCSF, and I'm going to open this afternoon's Presidential Chair lecture. And I want to start by thanking the Institute for Human Genetics, one of our main collaborators. But today I want to just do a quick shout out to the staff who have made this really event possible, including Beth Thew, Maura Piciota, Julie Harris, Erica Langner, and others. So thank you very much for doing all the work, the background work, for this whole week of events. We actually have two formal welcomes and introductions that will now follow. First, David Vlahoff, the Dean of the School of Nursing, is going to welcome you to the campus. And then second, Claire Brindis from the Philip R. Lee Institute for Health Policy Studies is going to introduce our two speakers for this afternoon. So thank you very much.
Thank you, Barbara. First of all, welcome to UCSF, everybody that's here, and for all the people that are tuning in. So why have this series? Well, UCSF has made an appropriate integration of precision genomics as a priority, building on the university's scientific strengths. And we're building on the history. The UCSF School of Nursing pioneered social analysis of science and new technology, starting with the work of Ansel Strauss and continuing through Adele Clark. We were one of the first schools to highlight ethics in practice under the leadership of scholars like Ann Davis and Pat Benner. The UCSF Presidential Chair Award is made each year, and that's through the Vice Chancellor for Academic Affairs. And Brian Aldrich, we really thank you for making this possible. And the Presidential Chair Award is bringing a distinguished scholar to campus in order to enhance interdisciplinary scholarship. This week is a series of lectures and seminars, and it's meant to formally launch CT2G, and that will be explained to you. It is a NIH-funded Center of Excellence examining the ethical and social issues in the translation of genomic or precision medicine into the clinic and public health practice. CT2G is an alliance of Kaiser Permanente and UCSF, and it's great to see the Kaiser Permanente people here in the audience, along with the UCSF people. And it is based in the School of Nursing's Institute of Health and Aging, and is led by School of Nursing faculty members Barbara Koenig, Carol Sumpkin, and Julie Harris. Now, Professor Claire Brindis from the Philip R. Lee Institute of Health Policy Studies will introduce today's speakers. The Presidential Chair Lecturer, Wylie Burke, and the distinguished commentator, Margaret Locke of McGill. Thank you. Claire, please.
Thank you, David, and thank you, Barbara, for enabling us to have the pleasure and the honor of introducing both of our speakers today. I could actually spend the next hour just introducing you, but because of the time and our desire to have this as interactive as possible after you hear the formal remarks, I just want to first say it's really an honor to have a pleasure of introducing you. And when we think about the topic of the talk today, which is guiding genomic translational practical wisdom for clinical care and health policy, and I think of both of our speakers today as being incredibly experienced. We have a lot of wisdom to share. And when we think about the complexities of the topics that we're discussing today, when I was looking at Dr. Burke's background, she's a professor of bioethics and humanities at the University of Washington. She's also the principal investigator of the University of Washington's Center for Genomics and Healthcare Equality, which is funded by the NIH as one of the centers of excellence in ethical, legal, and social implications research. And also she is a principal investigator of the Northwestern Alaska Pharmacogenomic Research Network. So her research addresses the social, ethical, and policy implications of genetic information. So you can see why she comes to the table today with so much breadth and knowledge to share with us. I want to just briefly say that I think of her as having a cutting-edge portfolio, and we know that sometimes cutting-edge people get a little bit bloodied, but clearly she is an amazing bridge builder, and she has the nuances of the language that is so clearly important in the translational efforts that are so necessary when we cross disciplinary boundaries and when we try to bring different stakeholders to the table. And not only that, but the conceptual frameworks bring in the whole issue of medical history and ethics. So I will be happy to applaud Wylie when she comes up, and then after her remarks, I'll have the pleasure of introducing to you a wonderful individual who will comment on her wisdom and translational efforts. Thanks.
Thank you very much. It's an honor to be here. I want to start by just talking briefly, referencing briefly some comments that I made 2 days ago at the first lecture. I argued that we have a current formulation, a way of thinking of genomic translation that I believe is too narrow. It talks about using knowledge about gene-disease associations in order to produce genetic tests, in order to produce new drugs and new treatments, and it keeps genetics at the center as though that were the whole story. Rather, I argued we really need to place genomic translation within the ecological model proposed by the Institute of Medicine that sees human biology as sitting in the center as a kernel, but surrounded by really important social and environmental influences on health that are very interactive with individual traits and biology. And I also argued that as we think about genomic translation, we really need to place it within a context that appreciates and understands the powerful way in which social conditions play a fundamental role in people's health and health status, putting genomics in its place. From that framework, I want to talk today about this idea of genomic medicine, which is getting lots of play, lots of attention, defined here from the NIH as using an individual patient's genotype information to direct his or her clinical care. That's the model that's being pushed, about which there is great enthusiasm. And it's a very important model for us to think about because we're in a technological period in which we are having rapid advances in our ability to identify genetic risk. It would be fair to say rapidly expanding opportunities. And so what does that mean, particularly if we're trying to put the issue of genomic risk into a broader context? Well, I want to start with a very straightforward classical medical genetics story, in some part to convey where some of the drama about genetics comes. So what we have here is a family in which a tragedy occurred. 16-year-old daughter died while swimming. And in the aftermath of this tragedy, the family came to medical attention trying to understand what was going on. And as they came to medical attention, the practitioners involved were extremely interested in the fact that a younger sister was having fainting spells, and a workup ensued. And in fact, in this family, a genetic diagnosis was made of a condition called long QT syndrome, which is an inherited arrhythmia, which can present with sudden death. And although the deceased child was not tested, one can infer from the testing that went on in the family that that was probably the cause of her death. This is an example where now that the genotype is known, care can be directed. The younger sister has a pacemaker in place, and there's a strong supposition that this protects her from the implications. protects her from the sudden death episode that her sister had. So this is dramatic. This is an opportunity for genomics via genetic testing to provide benefit. And what I also want to say is it's very non-representative of how genomics will touch most of us. This is a very, very much of an unusual outlier situation. But even when we look at genomics in ways in which it will touch more of us, we're still looking primarily at tailoring treatment for the outliers, in the words of two FDA officials who described our opportunities with pharmacogenetics. The poster child example of pharmacogenetics these days is the fact that we can use HLA testing, a particular gene variant in a particular HLA gene, to identify people who are at significant risk to have a dangerous hypersensitivity reaction if they are exposed to a drug called abacavir. Abacavir is a very effective HIV/AIDS drug, and a small percentage of people have this risk of life-threatening complication. It turns out that if you do the genetic test, you identify virtually all the people who have the risk. The test has a limited positive predictive value, meaning that even if you have that genetic trait, your likelihood of having this bad reaction in drug exposure is not high. But if you don't have this trait, then we're pretty comfortable that you're not going to have the reaction. Now, another crucial issue from an ethics perspective is that we have alternative therapies. So we begin to put together a picture in which, before we use this drug, we test people. And if you test positive, you get the alternative drug. And if you don't have the genetic trait that puts you at risk, you get abacavir. And as you'll note, a small percentage of people have the genotype, 2 to 8%, but we don't want to miss the risk in those 2 to 8%. But this is using genetic testing for identification of 2 to 8% of people who may have a genetic risk. In fact, they have a 50-50 chance of having that risk, and will only face that risk if they are in the position of taking abacavir. This is tailoring treatment to the outliers. It's important, but for most of us, most of the time, these kinds of genetic issues aren't going to be all that important. So in that context, we have to think then about what happens when we start rapidly expanding our ability to identify genetic risk. What kind of baggage do we accumulate when we do massive assessments of people's inherited risk? Well, if you do a whole genome test to answer, let's say, a particular pharmacogenetic question, you're going to get lots and lots of other information about inherited diseases, about gene variants that are associated with a variety of risks, with a variety of degrees of effect, and then lots of information that we don't fully understand. We need wisdom to figure out how to take advantage of this technological opportunity, how to capture the benefits that I've just been describing without overwhelming ourselves with information that may not be useful, may even be harmful. So I want to propose an Aristotelian concept called phronesis, which is defined here as wisdom gained from experience and morally informed mentorship. To be a person of phronesis or practical wisdom is to be the kind of person who in any concrete situation discerns the good and finds the right way to achieve it. The concept behind practical wisdom is that it's more than technical excellence. It is not the simply acquiring knowledge and skill, but acquiring an understanding of context and the ability to appreciate the contextual factors that matter. So I want to take a detour here from genomics and talk about what we learn from wise clinicians and patients about what practical wisdom might constitute when we're talking about the healthcare setting. I want to make reference in particular to a very interesting study that was undertaken at Vanderbilt University where they asked their colleagues who's a really good clinician in this area. And they accumulated references and ultimately a list of 50 master clinicians who they called healers. And they went to talk to them, had long interviews in which they discussed what does it mean to practice good clinical care. And here's one of the quotes. I took a class with a famous psychiatrist. He had all sorts of ideas about how to connect with patients, lean forward, sit on the edge of your chair. I asked, wouldn't it be better just to be interested in your patients? And in fact, in these interviews, what we hear these doctors talking about first and foremost in the center of medical care is the crafting of a relationship between physician and patient. Listening is the most important thing, trying to understand who this person is and understanding that patients bring to this exchange their own expertise, which is as essential as the clinicians in crafting that therapeutic alliance. They also talked to patients, and those patients talked about what they liked about doctors they liked and what they didn't like about doctors they didn't like. And I'm just going to give you one quote here. He started asking me all sorts of questions. You begin to think, well, he's not just dealing with my pain. He's seeing me as a whole person, and I thought, I am a whole person. I can be a whole person again. This also was what came through. And in all of the patient interviews, there is conversation both, again, about the value of these dual agency relationships, but also unfortunate anecdotes about doctors they fired in the past who didn't listen to them. Who paid attention to certain body parts and made them feel that they were just a collection of body parts. So what does that have to do with genomic translation? Well, I think through the lens of practical wisdom, understanding what it is that we're trying to accomplish in a clinical care encounter, it's really important to say that genomics is a tool. And like all tools, it will have good applications and other circumstances where it just isn't the right tool. So the question we have to ask about genomics is, how does it help? When does it help clinicians and patients? And once we've figured out what it can do for us, we also have to ask the comparative effectiveness question, which is, how does it compare to other ways of accomplishing that same problem? What can it do for us that is uniquely valuable for this kind of technology, knowing that we've got a whole armamentarium of technology growing all the time, but starting, of course, with the fundamental tool of talking to patients. Because part of what's going on here is that personalizing healthcare is mostly not about genetics. I think what we can elicit from the doc and patient interviews is that, in fact, personalizing healthcare is, first of all, creating a relationship so that doctor and patient know each other and can negotiate a variety of healthcare options together. But even when we get to a more concrete discussion about the use of a variety of medical tools, there are endless examples of ways in which physicians will help patients to personalize their health care using a variety of different interventions. And I've just listed a few here, but the list could go on. We know now that pregnant women were at much higher risk of H1N1 flu adverse events than other folks. That was a tool to personalize health care. Burnout in an Alzheimer's spouse, that's a whole other kind of issue that requires another kind of support. Exercise program for a patient in a wheelchair. I had a patient in a wheelchair who was very concerned about her cardiac health. She and I researched it. We actually found an exercise program in the rehab department that looked like just the thing. It had a very interesting aerobics program, mostly involving upper body. It turned out it only had classes between 2 and 4 p.m., and my high-powered executive patient in a wheelchair couldn't get to them because we haven't quite figured out how to make programs for people in wheelchairs at the kind of hours that she needed. But the point is, she needed something tailored, and that had nothing to do with genomics, immunizations for a traveler. The other point that we can draw from this kind of conversation is that one size fits all is really not a bad idea a lot of the time. There are a lot of interventions that work well for all of us. I've listed a few here. Let me emphasize the healthy diet and the regular exercise. We may indeed need to tailor, as I've just told you, how we do the exercise, and we always tell people to pick exercises that they enjoy. But there is a universality to the notion that we need healthy diets and we need regular exercise, and we don't need genomics to tell us that or to personalize. But there is a tremendous interest in gathering this voluminous information that might come from whole genome analysis and figuring out a way to weave it into regular, everyday clinical care. This is a quote from a study that is, in fact, taking patients who are going through a wellness program and doing whole genome analysis and trying to figure out what genetics adds to a wellness program that involves a lot of clinical data and a lot of coaching for exercise and so on. And the quote here is really to illustrate how people are thinking about this. Routine incorporation into primary medical care also calls for its inclusion in assessment and promotion of wellness and health. There's an assumption being stated here. We have this information, we're beginning to use it for treating disease, but really we should be using it for wellness and health, at least is how I read that quote. So how would that work? So I just want to reflect on one particular example that illustrates, I think, the kind of complexity that we get into when we think about genomics being part of a health and wellness program. So this particular paper is the latest in a whole line of research that is trying to identify common variants that contribute to breast cancer risk. So we know that there are rare conditions, mutations in BRCA1 and BRCA2 that are associated with very high risk of breast and ovarian cancer. But this study is asking a different question. In the population, can we find common variants that contribute in a small additive way to the likelihood that a woman will have breast cancer? And indeed, they found in this particular study 41 genes. They estimate there may be another 50 or 100 to go. And they have taken their data and they have estimated the distribution of risk, basically the variance of risk that is associated with these 41 genes, with gene variants in these 41 genes. And there's a fundamental message here. They've analyzed their data in two ways. They get two slightly different curves. But the fundamental message here is that most women have a risk that's around average. A little bit above, a little bit below, but around average. The other message from this curve is that there's a small number of outliers. You can figure out from this kind of analysis a small set of people who have a higher risk, not as high as BRCA1 mutation carriers, but a higher risk than population, and another small set of people that have a demonstrably lower risk. The question is, how does that help us? What can we do with that information? Well, we could go out and take average risk families where there's a little bit of breast cancer. We're not worried about the BRCA mutation. And we could do these tests and we might be able to refine people's risks differently. But would we offer them different kind of health care? Should we offer them different kind of health care? And if we did get that kind of analysis, what else would we be providing? Anxiety, risk? Certainly, women in our society are already anxious about breast cancer. They receive lots of messages. It's not clear that these kinds of messages would be helpful. But in fact, there's already some thinking along these lines. And in fact, the paper I'm referencing here is talking about precisely the kind of data I showed you. And it's asking the question, should we be doing risk stratification using gene variant effects of small size, the ones that I've been showing you, in order to guide how we approach, from a health policy perspective, cancer screening, in this case, mammography screening. The general idea of this would be to look at those outliers And so you say on the low-risk side, maybe they don't need to be screened at all, or maybe they get screened very infrequently. On the high-risk side, maybe we screen them more intensively or we start earlier. The goal here is to achieve, in this perspective, either the same degree of cancer prevention or possibly more cancer prevention, finding more early cancers, in other words, and at the same time reducing known harms of screening, reducing overdiagnosis and the unnecessary treatment that goes along with it, risks of the screening procedures, and, of course, cost. So here's an idea which carries with it a whole lot of questions. The questions start with, what's the impact of that information on the individuals who might then be routed to a more tailored screening program? What's the screening program? What exactly are the screening tests that we do? And how do they compare with our one-size-fits-all now? To what extent will we, in fact, realize significant benefits in either cost or better identification without loss of detection of early breast cancer? These are very serious questions that need to be studied if we're going to go down this route, but we need to think very carefully if that's the route we want to go in. What we're basically talking about is the general caution that we bring to screening programs, which is we want to be cautious looking for disease, or in this case, disease risk, where none is expected. We want to be cautious about adding information in to the mix of healthy middle-aged and older women, because every adverse outcome of screening is iatrogenic and potentially preventable. Here we're talking about genetic screening as a path to another screening program, and so we're talking about screening within screening and the possibility that that added genetic screening could add benefit, possibly, but could also add harm. That's the question that we have to be paying attention to. And because genetic information involves gathering lots of new additional information, you have always, as one of your most significant harms, the known cascade effect of medical technology, where you gather data, you maybe test those 41 genes, maybe you did it with the whole genome and you got lots of other genes too, but maybe you just looked at those 41 genes and some of your data were ambiguous or difficult to interpret. And did that lead to further tests and treatment? Did that itself lead to harm? I want to go back to the more dramatic and arguably more straightforward case to say that even there, the notion of genomic screening raises questions. So we had a 16-year-old who died while screening. We would like to have found that 16-year-old earlier. We would have liked to have her have a defibrillator like her sister, so that she could have, or a pacemaker, sorry, like her sister, so that she could have survived the event that in fact killed her. And that's a screening proposition. So we do have to take very seriously the possible benefit from genomics of screening to detect these very high risk and treatable conditions, find them before the adverse event, which in this case may be death. But the family shows us that this is complicated, because when the workup of the family was done, it turned out that the mom had the condition too. She's middle-aged. She's got a quasi-abnormal EKG. She's got the genetic trait. She has never had, as far as she knows, symptoms of this disorder. Her mother does not have the disorder. Her father died at age 65. He had a classic history of a myocardial infarction, chest pain, and went to the hospital and died during that hospitalization. One wonders if his death had something to do with long QT syndrome, whether he had it. That's not known. The point is that even in what would seem to be a clear-cut case, if we used screening to identify the child, We will certainly also identify family members whose course is going to be much more benign. It may be worth it, but this is part of the burden and cost of screening, and will certainly be part of genomic screening. So what do we have in front of us? We have a very challenging transdisciplinary research agenda. We need to figure out how to find meaningful knowledge from massive amounts of data. We need to figure out what are the benefits and harms of genomics, both in terms of testing, where there are very tangible risks of harm, and in the more general question of, can genomic knowledge help us to do some of the things we're trying to do in healthcare better? As we do so, I think it's very clear that the we needs to be broadly inclusive, that we need to invite to the table a broad range of disciplines, particularly to understand what is the impact of pursuing this kind of information on individuals in their daily lives. There's another challenge, and it's a challenge I'm happy to say that CT2G is thinking about, and that is negotiating the research clinical interface. In order to pursue the kind of research that we need to do, we're going to need to connect genomic data with health data. And that means we have to think about when and how clinical data can be used in this enterprise, what kinds of informed consents are necessary. Are there times where we can just take clinical data and maybe take biological samples without formal informed consent? And to the extent that that's acceptable, what kind of information do we need to feed back? What do clinicians and patients need to know? And then, of course, as we do the research and generate research information, are there times when it needs to get fed back? If we're doing a genomic analysis to study breast cancer risk, but the nature of the analysis results in our acquiring knowledge about long QT syndrome, what's our responsibility? These are serious questions that will need to be addressed. As John Eisenberg some years ago said, technology is rarely inherently good or bad, always or never useful. The challenge is to evaluate when and where, for whom, at what point in an illness or as a screening wellness intervention. As we pursue this kind of question, we also have to have in mind this clear kind of understanding that there are universal health needs, and genomics is kind of icing on top. In other words, to the extent that genomics can offer some interesting new tools, it will not replace our very fundamental health needs and the quandary that we have in our society that they are not universally accessible. What we need then, I would argue, is meaningful public deliberation about a number of things. So we've got an ambitious research agenda, but we also have a need for public input on a range of very serious issues that genomic translation faces. There has been some really important foundational work around the idea of bringing the public together for meaningful deliberation about policy issues, creating opportunities for truly informed discussion, not just surveying people or interviewing them and assuming they've got fixed and meaningful ideas that can be used, but giving them an opportunity to engage with the issues and to share with each other what Leonard Fleck has called public reasons, that is, asking people to think through issues of resource allocation or research agenda from a collaborative and communitarian perspective, justifying reasons. And that's tough in the United States, right? We actually have a very difficult time getting to the kind of public deliberation that we're going to need to have to figure out how we prioritize genomic research and how we prioritize this idea of pursuing genetic risk information in individuals. Fortunately, we do have some examples, some very positive examples of the use of deliberative democracy methods to engage people in relevant conversations. So I'm just citing here a couple of 3 studies, actually, 2 at the Mayo and 1 in British Columbia, 2 led by Barbara Koenig, in which deliberations were convened. Members of the general public or members of a healthcare system were convened, chosen to be representative, deliberated over days so that they could actually engage in a meaningful way with the topic. These were all around development of research resources, biobanks, and generated very important and useful and actionable feedback about some of the critical issues that arise in creating these research resources, including recommendations for the involvement of community in governance. So we begin to see at least one of the critical paths forward to addressing some of these tough issues. I'm just going to stop with a little bit of practical wisdom from Mark Twain. I don't know if he actually said this, but it's attributed to him. Supposing is good, finding out is better. It's a great concept, and for people who do empiric research, it's a lovely idea. Let's go find out. The difficulty with genomic translation, I think, is that we really have to ask ourselves, what is it we are supposing? Are we supposing that this is a new tool to get us all to wellness? Are we supposing that it's a way of refining some of the medical care we do, or revolutionizing it? What are we supposing? And once we've figured out what our assumptions are, what is it that we need to find out? And of course, who's the we? How inclusive can we make that enterprise? So thank you very much.
Thanks so much, Wylie, for that very thought-provoking lecture. And fortunately for us, we have Dr. Margaret Locke to help us start thinking about how do we respond. Margaret is the Marjorie Bronfman Professor Emeriti in Social Studies and Medicine in the Department of Social Studies of Medicine and Department of Anthropology at McGill. We're very interested in her own trajectory and her own history because she's actually a Renaissance woman herself, having started work and conducted some of her original research in the area of biochemistry, and then after a seemingly a life-changing trip to Japan, discovered the field of anthropology. And we're very lucky and fortunate that we can take partial credit for some of her star trajectory, having that she received her training at UC Berkeley and UC San Francisco in medical anthropology. And after she left UCSF, she went to McGill University, where she established an internationally recognized medical anthropology program and has continued to be extremely productive and prolific throughout her career, spending a lot of her time on the issues of the global impact of emerging biomedical technologies. So with that introduction, we'd like to welcome you here.
Yes, I'm dispensing with PowerPoint today, so make a change. It's a great pleasure, as always, to be back in the Bay Area. It's always quite a heady experience, one way and another. And I should just point out very quickly that the biochemistry I learnt was done a long time ago, before we had even discovered the Krebs cycle. So you can tell, A, how old I am, and B, how much we've done in the intervening time. Wylie's presentation today was absolutely marvelous, as one expects, and it's replete with important and very, very timely information, insightful knowledge for us to start building on. It is, as the anthropologist Mary Douglas might have said, good to think with. We've obviously transcended the era when wild claims were made all too often about the triumphs and future promise of genetics and genomics. And we're now at a juncture where, as Dr. Burke makes crystal clear, we must think through with exceptional care how best to translate and apply the genuine insights that we've accrued, translate them into policy making for use in the clinic and among populations at large. In her talk today, Wylie, as she also did in her Monday presentation, has emphasized the potential limits and strictures of so-called personalized medicine. She argues that we should not assume that it's just a matter of time before we will all have tailored treatments based on our own genomes. And she notes that there are several clear examples of how healthcare can be improved by implying individualized genomic knowledge, as she presented today. But she also argues that neither genotype assessment nor related drug development are likely to play a major role in the prevention of common complex diseases that represent, of course, by far the major health burden to populations at large. An argument that applies globally today and not only to the so-called developed nations. If we're to improve population health rather than confine our efforts largely to individual cures, then, Wylie asks, how might we best go about this? She places the concept of practical wisdom at the center of this endeavor, and wisdom that results from the experience not only of experts, but also from, of course, patients and the public. With this in mind, I want to turn to two specific points in this short space of time. First, the expectations about genetic testing that appear to be held by the public at large and by patients and research subjects before and after encounters in clinical and research settings. And second, I want to turn very briefly, to consider recent expert reconceptualizations about the relationship of genes and environment, of nature to nurture, and what this implies for genomics and for population health. Although a large number of people are apparently amazingly interested, in my opinion, surprisingly interested in learning about their ancestry by paying for genetic testing from 23andMe and the like, in contrast, research, and I think here it's fair to say particularly social science research, has shown that great caution has been exhibited over the years by most individuals who come from families where destructive, often deadly single gene disorders are present. It's estimated that only somewhere between 20 and 30% of adults at risk for such single gene disorders or for carrying a fetus that may be at risk are willing to undergo genetic testing. A finding that really hasn't changed much over the past decade, although these numbers vary considerably from country to country and, of course, differ according to the disease in question. It's also been shown that a good number of people, when tested, ignore or challenge the results, and no doubt this situation exists because uncertainty, disbelief, and worries about repercussions on kin they must influence people's responses to test results. Furthermore, concerns about being subjected to social discrimination, notably in terms of insurance coverage and employment difficulties, as well as possible stigmatization by relatives or acquaintances, contribute to the reluctance of many people to consider testing. Responses to testing also depend on whether or not reproductive decision-making is implicated, and of course the age of onset of the disease in question, the severity of the condition, and whether or not its actual occurrence can be predicted with certainty, all affect people's decision-making. In addition, for virtually all the single gene disorders, few preventive measures can be recommended for those who test positive, and effective treatments are virtually non-existent, with one or two notable exceptions. The now classic ethnography written by the anthropologist Rainer Rapp, based on work conducted some years ago now in New York City, found that many pregnant women, when forced to make decisions about genetic testing, were non-cooperative, and that they frequently interpreted the risk information they'd been given in ways that were quite different from that of the genetic counselors. Rapp argues that women and their partners must confront what she describes as a gap, which is inevitably created among statistical estimations of risk based on population databases, individual concerns about undergoing the actual test, and doubts about the significance of the results for their well-being and that of their future baby. Making so-called rational decisions simply is not possible for these women and their families, and also, of course, for their families. Religious beliefs, she found, played a great part in the decision-making for many involved people, as did family economics, earlier reproductive experiences that extended family members had undergone, and attitudes towards disability in general. In other words, we have a huge number of variables and factors at work here, and they vary considerably according to the families in question. In some families, the pregnant women had been made to feel by their families responsible for the so-called problem that had arisen in the first place. Rapp also found that despite a policy of non-directive counselling, the counsellors sometimes modified the information they gave to women according to the assumed ethnicity and educational level of the individual in front of them, so that some women were, in effect, being encouraged to terminate their pregnancies, although the counsellors were apparently really not fully conscious of their own biases. So these findings make it very clear just how difficult can be the notion of a therapeutic alliance between clinicians and their clients or patients, and there are many more examples such as this. And obviously a large investment of time in thoughtful, reflective listening on the part of clinicians is called for, in which the reality the family is confronting must be given due consideration. So practical wisdom, the practical wisdom that Wylie talks about, should be obviously at the heart of exchanges that take place in connection with the possibility of testing and what the outcomes are likely to be. But turning to testing for susceptibility genes associated with complex, usually adult onset diseases raises considerably different issues. And in these instances, interpreting the significance of estimations of risk on the basis of genetic testing often becomes extremely problematic. So I'll briefly introduce a few results from a randomized NIH trial that I was involved with called REVEAL, which was designed to assess how healthy people respond to information given to them about the ApoE gene, which is associated with increased risk for late-onset Alzheimer's. The research subjects all came from families where late-onset AD had been diagnosed in one or more relatives. And by definition, these individuals, of course, are at increased risk for AD dementia as compared with the general population. Before the trial, prospective subjects attended an educational session in which genetic counselors presented current knowledge about risk for AD, including both environmental variables and genetic susceptibility. Those subjects who then chose to continue in the trial, as the majority did, were tested in order to determine which particular form of the 4 ApoE alleles they carried. Different levels of risk are associated with these alleles, and the one known as the E4 allele puts individuals at greatest risk for AD. During the education session, everybody had been taught about the ApoE gene, but they had also been told very clearly, with helpful visuals, that the presence of the E4 allele is neither necessary nor sufficient to cause AD, and that environmental variables, including diet and indeed many other genes, are implicated in the onset of AD. Furthermore, they were taught that, above all else, age puts us all at risk. When my small group of researchers conducted open-ended interviews with 79 of these research subjects 1 year after they'd received their genotype and risk estimates, and they'd also by that time received several rounds of follow-up counseling, we found some surprising results. only 27% of these highly motivated individuals remembered their genotype. 23% had essentially forgotten their results, and another 50% had only retained the gist of the information and often described themselves as having either good or bad genes. Among the 3 people who were given the highest risk estimates because they had 2 copies of the E4 allele, one responded, "I'm still totally confused, although I know I have 2 of them, whatever those bad things are." And another individual laughed and said to us, "Well, I know what to tell the children now. Maybe get it, maybe not." One individual came away with the idea that she was destined to get AD because of her family history, and this was not an impression she should have taken away from this study. Everyone introduced variables such as diet, exercise, crosswords, and so on into the discussion that they regarded as important preventive measures. And part of the reason for these findings, I believe, is that even those people at the highest risk were given a remaining lifetime risk for getting Alzheimer's as just over 50% by the age of 85. And most people went away thinking, well, if I live to 85, then I'll start bothering about this. But these people are in their 40s and 50s. And aside from these people at the highest risk, everyone else was given much lower risks. These estimates, note, were based only on age, family history, and genotype alone, and not on any other variables. And it could have been, well, not at this stage, but it would be possible to make this considerably more sophisticated. Furthermore, risk estimates rarely displaced family knowledge. The participants are brought with them to the project, and a good number continued to believe that family resemblances or personality types would be the deciding factor. If you look like you're affected relative, then the cards are definitely stacked against you. The entire sample size used in the trial was over 400 individuals from 4 different research locations in the US, and all of these people had high school education, and a very large number had college education as well. So I think that these results strongly suggest that people will inevitably conflate probabilistic information based on genetic testing with their prior knowledge based on family law, no matter how well informed they may be in the latest scientific findings, and perhaps no matter how well educated they are. Surprisingly few people made changes in their lives as the result of going through these tests, although a lot of them had the best of intentions to change their health insurance, but in the end, many didn't get around even to that. If an effective medication for AD becomes available, then these results, of course, may change somewhat. And as they become older, some of these individuals may well decide that they want to take the results that they got quite seriously. The big problem then is that they may well not be able to find the scrap of paper on which they wrote their result and then stuffed into the back of a drawer and couldn't remember where they had put it when they were talking to us. So it may be that the very uncertainty associated with susceptibility genes and the knowledge that environmental variables, including diet, exercise, and so on, are very important in preventing or circumventing complex diseases will ensure, as Dr. Burke argues, that health benefits do not accrue from simply from genetic testing, and genetic testing becomes, in effect, a moot point. And as she noted indirectly in one of the slides she presented today with respect to AD, the question of care and support for care of family members who have AD is probably of more importance than just about anything else in sustaining the well-being, including the health and illness risks of the whole family. So I want to turn briefly to my second point. Perhaps some people in the audience are already aware that the theory of inheritance of acquired characteristics postulated by Jean-Baptiste Lamarck early in the 19th century is undergoing a surprising revival, albeit in modified form. Although the notion was long ago abandoned that the use or disuse of body parts results in evolutionary change, certain researchers have continued to propose from Lamarck's time that forces internal and external to the body, in addition to genes, contribute to the phenotype of ensuing generations. This is a position now grounded in molecular biology and is strongly upheld by people in the expanding field of epigenetics. The assertion that variation in genomic sequences alone cannot account for phenotypic differences inevitably raises ontological concerns similar to those apparent in the days of Lamarck. If the gene is no longer understood as the fundamental force of human life and is not in Evelyn Fox Keller's words, part physicist's atom and part Plato's soul, then the hoary problem of the relationship between nature and nurture has to be confronted head-on. Michael Meany, whose specialty is behavioral epigenetics, is one of an increasing number of researchers who argue that it is now beyond debate that the genome can operate independently of its environmental context, both external and internal to the body. Hence, an entanglement of nature-nurture must be recognized, and the function of a gene can only be understood within the cellular environment in which it operates, rather than as the determining force. In turn, this cellular environment is itself endlessly modified by signals emanating from other cells, the organism itself, and external environmental sources. These signals turn genes on, allow the expression of genes, and also switch them off when at certain times, which may have significant consequences for health. Early in life, epigenetic markings transform the pluripotent cells of the embryo into the differentiated tissues and organs of the human body, an activity that persists lifelong. In addition, less predictable, probabilistic epigenetics permit all organisms, humans included, to respond specifically to environmental variables. This type of epigenetic adaptation allows organisms to adjust relatively quickly to apocalyptic happenings such as famine, and thus to override the slow process of natural selection. An emerging reality of the present era, labeled by some as the Anthropocene, is the ceaseless, massive, human-made transformations taking place at an ever-increasing rate that bombard environments and hence human health. It's clear that a semi-permanent mismatch, as it's called, is emerging among environments to which we are genetically adapted and the ever-shifting human-made environments to which our epigenetic markers are responding. We're increasingly out of sync with ourselves, so to speak. Not surprisingly, this situation affects most dramatically those who are economically deprived, severely exposed to toxins of various kinds, are chronically malnourished, and subject to violence of all kinds. And the numbers of us living in such situations is undeniably on the increase. With respect to genetics, then, several things are clear. First, that we should no longer think of disease and ill health as caused by a certain percentage of genetic input and a certain percentage of environmental input, with a missing percentage as yet to be explained. Genes and environments are entangled from conception on and cannot be partitioned out one from the other, except effectively quite often in the case of relatively rare, highly penetrant genetic mutations. Second, if we want to create a genomic research agenda to generate knowledge about population health and how better to ameliorate it, then I couldn't agree more with Wylie Burke. Rather than a narrowly defined concept of genomic medicine, we need a conversation across disciplines. Such a conversation will attempt to show how historical, political, and social environments writ large come to be biologically embedded in individual bodies via epigenetic marks, and with what consequences for everyday life, for health and illness, and for life expectancy and early death. And if we think through this, we begin to understand that the question of the allocation of responsibility for ill health needs, as we so often do it, we turn it into something that is an individual responsibility. The question of this allocation of responsibility needs, as Wylie has suggested, to be revised with some urgency. Thank you very much.
Thank you. Two very spectacular talks. I think I'm going to open it up for just a couple questions, and so that we don't have a handheld mic, so I'm going to either repeat them, and I'll call maybe both Wylie and Margaret up to answer, and if I will lead off with an opening question if someone is, if no one else is ready to speak right now. So I actually happened to get a call today from a reporter, and apparently a local Bay Area company called Council Genetics is about to announce, or has recently announced, that they're going to add breast cancer screening for BRCA2 and other genes to their panel of tests. And it struck me that that's an interesting, the question about the ethics of that is interesting to think about the tension that you raised between the idea of a virtuous clinician who might be exercising phronesis and perhaps figuring out how to actually prescribe or offer these precision medicine technologies, as opposed to a different approach, because some of these direct, although there would be physician involvement in this case, it's more complicated. So how does that play out in this issue of how we're going to figure out how to harness these new technologies appropriately for population health? And I'd be interested in either one or both of you in talking about that.
Well, there's clearly not a simple answer to that question, but I think it raises three pieces. Piece number one is the place in our society for consumer genomics. Really what I have been talking about is trying to use genomics tools in a productive way within the delivery of healthcare. And an assumption I am taking is that delivery of healthcare uses communal resources. It is a societal investment, and we all have a responsibility to do that, to use resources carefully and appropriately. The question is begged whether it's okay for consumers to just buy whatever they want. I think that's, first of all, a safety issue. It's perhaps a truth in advertising issue. That is to say, if people seem to be able to handle information that they themselves are voluntarily seeking, then we just want to make sure they really know what they're getting. So I think that's a serious issue. But there's also what we might call a raiding the commons problem. That is, you go out and you get your consumer information, and then you bring it back into the clinic and take lots of doctor time, perhaps trying to sort out something that the doc would have not gone in that direction in the first place. So I think those are the issues that come to fore. But the other issue that this one raises is the appropriate use of genetic information in reproduction. And I don't think we have a societal consensus about that. That's clearly something where we need public deliberation.
Vincent Adams has a question.
Well, I guess how does ethics, I mean, on one hand, how does ethics deal with this problem of the floating stakes, you know, that these problems change really dramatically with different diseases? And I would ask Margaret, you know, what is an ethic of an epigenetic world? I mean, what do we do with ethic when it comes down to the fact that, you know, there's really very little that it, I mean, it's going to change medicine, but we don't really think about the ethics of it when it's, I mean, I just don't know. How do we approach an ethical, you know, proposition?
My answer to that question is it's something that I'm trying to think through, because obviously all this stuff is extraordinarily new, and there isn't a body of literature and received wisdom that one can go to at all. But I think from the point of view of a social scientist particularly, that the whole way in which ethics bioethics has been conducted to this time, which is essentially an individualized approach, is one that we don't abandon at all, but that we now need also simultaneously to go to another level in which we begin to understand that there's an ethics associated with political activity. And if we start looking at the people who are the most vulnerable in this world, that we've always known about, epidemiologists have told us forever, but now we have this, we have molecular markers, which means that people are really going to start listening more intently to what the epidemiologists have been saying. And if they add on to that the social science argument, you have to go back and look historically at what has happened to various groups of people over time and through different places. It then becomes clearer and clearer that we need to allocate responsibility and the idea of ethics associated with responsibility into larger frameworks at times. Obviously, something like genocides, the Holocaust, and so on come to mind right away. This is not something for which individuals can be held responsible, but the suffering that is probably almost certainly intergenerational suffering. I've been doing a lot of work with First Nations in Canada, the same pattern there. And they call what they've been through a genocide. But there are other aspects, like what food people what is on the shelf when you go into the supermarket, which of us can afford the nutritious stuff and which of us can't afford the nutritious stuff. You can all go on and elaborate on this in your own heads. I think this is an ethical question. It's not just a political, economic question, and it needs to be framed that way.
Thank you. I don't have much to add to that wonderful discussion. I did just want to briefly comment about a severe disease raising different questions from the common complex diseases, and I think that's true. I don't think we're going to have a universal ethic of genomics. I think it's going to be very context related, that the ethical issues are going to be very context related. And I think genomics has had a problem historically with being focused so much on those dramatic outliers. So where I think we're behind is in thinking about the complex diseases where genomics is one part of a very complicated puzzle that now includes epigenetic changes, and what are the ethical implications surrounding both research agenda and use of that information clinically. Lots of work to do there.
Well, thanks. Join me in thanking the speakers once more. Thank you.